Our lecture today is about class 3 malocclusion. In the last lectures we discussed class 1, class 2, division 1, class 2, division 2, and today we're going to finish with the class 3 malocclusion. So starting with the definition, according to the British Standard Institute, class 3 incisor relationship where the upper incisal edge where the lower incisal edge occlude anterior to the cingulum plateau of the upper incisors. That's the class 3. Again, that's class 3 can be as this one, which is a lot anterior to the cingulum plateau, that we have a reversed overjet, can be an edge to edge, and can be with a positive overjet, while the upper lower incisors is anterior to this area, the middle third, the cingulum plateau. In this side we have a positive overjet, but a minimal one. Don't forget that angles classification means that the buccal cusp of the upper 5 occlude in the mesobuccal or the buccally groove, the mesobuccal groove of the lower 6, where basically the mesobuccal cusp of the upper 6 is posterior to the groove of the lower 6. That's an angles classification of class 3. So what is the etiology / feature of the malocclusion? As always, skeletal, soft tissue, and dental factor. Skeletal factor, we discuss it from anteroposterior, vertical, and transverse. So usually patients with the class 3 malocclusion, they have a orthognathic mandible. So if you can see, we check the zero meridian line, we can notice that this mandible is the orthognathic. So why do we have a orthognathic mandible? It's linked a lot with genetics, that genetics play a major role in having patient having a orthognathic mandible and class 3 malocclusion. And one of the evidence for that is called the Habsburg family. And this Habsburg family, they ruled in Central Europe for quite a time, in which they used to not marry foreigners. They have to marry from within the family, and for that reason they got a lot of hereditary diseases. And as you can see, this is the family chart where the black color indicates death. And as you can see, there's a lot of death happened because of hereditary disease. So then with this disease come as well the features that can be inherited. And as you can see, that most of them, they have a class 3, mainly due to orthognathic mandible. So these are picture for the family with the Habsburg. They have a orthognathic mandible. Just notice that the way that the European or the Caucasian have a class 3 orthognathic mandible, usually they have a orthognathic chin. And this will be important now when we discuss the management, because when a patient has a prominent chin, that will make it difficult to retract the lips. As you can see here as well, this patient has a prominent chin. He's a class 3 but prominent chin. Class 3 can be caused by mandible, and it can be caused by being orthognathic, and it can be caused by maxilla being retrographic. So in the clinic, how can we diagnose a retrographic maxilla? First, you need to remind yourself with the anatomy. Now, maxilla is a huge bone in the middle of the face. It has multiple processes. So this one here is the alveolar process of the maxilla. This one is the nasal process of the maxilla. This is the infraorbital process of the maxilla, while this one is the zygomatic process of the maxilla. So whether the maxilla is small, hypoplastic, or the normal size but it's sitting posteriorly, we call it retrographic maxilla. When this alveolar process goes back, it will take with it all this structure. So whenever we try to evaluate and examine a retrographic maxilla, we need to examine the maxilla and the processes as well. So if the maxilla is retrographic, as we can see here, first the nasolabial angle will be affected because the alveolar process and the teeth will be retracted posteriorly. So the nasolabial angle will be increased, unless the tip of the nose is downward, so that will compensate. But anyway, being retrographic maxilla, first sign is increased nasolabial angle. The second sign, something we call it malar hypoplasia, which basically the patient, because they don't have this zygomatic arch. If you compare it to this patient here who has a cheeks, so this patient here, he doesn't have a zygoma, and also we call this malar hypoplasia, and also he does not have the infraorbital process. So you can see here that this area is flat, while this one here, they have a cheeks. We call this paranasal hollowing. So the patient who has a paranasal hollowing or malar hypoplasia due to the retrusion of the infraorbital rim of the eye and due to the retrusion of the zygomatic process of the maxilla, you can see that this area became empty. We call this one paranasal hollowing, and this one malar hypoplasia. And together with the increased nasolabial angle, that's how we diagnose patient with the class 3. As you can see here, that what we called about the paranasal hollowing. The area near the nose is hollow, is flat. There is nothing there because of the retrusion of the maxilla. So a patient with this maxillary retrognathism and mandibular prognathism, we expect a good class 3 malocclusion. So basically the most common cause of class 3 is a hypoplastic maxilla or retrognathic maxilla rather than mandible. So most common cause first come the maxilla, the second one is maxilla and mandible together. It's quite common in the class 3 to find the etiology maxillary retrusion and maxillary prognathism, then the mandibular prognathism as a cause. Don't forget that class 3 malocclusion can be seen in a class 1 skeletal and class 2 skeletal as well, whenever you have a local factor that resulted in a class 3. For example, if a patient has a missing lateral, the upper incisors will try to be moved posteriorly to compensate for the spacing of the missing lateral, which will result in a reduced overjet and probably class 3 malocclusion. So what are the features of skeletal features of a class 3 patient? First, and by the way, they are kind of the opposite for the class 2 skeletal. First, they have a reduced cranial base angle. As we said last time when we discussed class 2, we have the anterior cranial base and we have the posterior cranial base. So when the cranial base angle is reduced, it means that the posterior cranial base carrying the mandible with it will move forward. So that will result in a more forward position of the mandible. They have shorter cranial base as well. Usually, the maxilla is short, small, and narrow, while the mandible become broad and wide. For that reason, we might have a crossbite, and also when you have a short, small maxilla, you are expecting to have a crowding in the maxilla, while because you have a broad and big mandible, you are expecting to have either well-aligned or spaced mandible. All right, and definitely you're gonna find a crossbite. We'll have an obtuse nasolabial angle, which is the opposite of a class 2 patient, so this angle will be increased on these patients. So what about the vertical relationship? Now, when patient have a class 3 malocclusion, he can have either posterior growth rotation or anterior growth rotation. So when we have a posterior growth rotation, that means that the mandible is going to go downward and backward, which means he will look less severe class 3 patient. While if the mandibles go down, forward and upward, which means that the mandible is going to move forward, that will make him more severe. For a moment, you would think that a patient with anterior growth rotation will be easier and much better for us to treat than a patient with a reduced and anterior growth rotation of the face. But the fact is not. We prefer patient with anterior growth rotation. Even though the rotation will make the malocclusion looks more severe, but having a positive overbite guarantee the stability of the correction of the class 3, as we're going to see later. So when you correct the overjet, the reverse overjet, if the overbite is open or reduced, as we can see here, there's a big chances of relapse. But if we have a good positive overbite, then the lower incisors will maintain the position of the upper incisors. Plus, most of our mechanics are extrusive mechanics, so that will be here. We're gonna worsen the anterior open bite and cause more posterior growth rotation of the mandible. So basically, we prefer the anterior growth rotation. Transverse. In a class 1 and a class 2 in malocclusion, we say always transverse is not an issue, but this is not the case in a class 3, because in these patients usually, and one of the causes of the class 3 is a orthognathic mandible, there's a good chance that we might have asymmetry due to the asymmetrical growth of the mandible. So it's quite often to see this, and whenever you have a class 3 patient, you need to spend more time assessment of the asymmetry. As we can see here, the chin is deviated to one side. Soft tissue in a class 3 malocclusion, usually soft tissue are helpful. They are trying to compensate for the malocclusion by retroclination of the lower and proclination of the upper. However, sometimes when a patient have tongue thrust, if they have a posterior growth rotation, and that will kind of worsen the malocclusion. So about dental factor or the dental features, usually patient with a class 3 malocclusion, they have a class 3 molar relationship, as we can see. They usually have a reverse overjet, and sometimes open bite might be seen. Maxillary incisors will be procline, as we can see here, trying to compensate, while the lower incisors are retroclined, trying as well to compensate for the class 3 malocclusion. As we mentioned earlier, the patient will have a narrow maxilla and he will have a wider mandible. For that reason, you are expecting to have more crowding in the maxilla and less crowding or well-aligned dentition in the mandible. You're expecting to have a crossbite as well, as we mentioned before. And if you have a patient with pseudo class 3, in which the patient will achieve edge to edge, then displace the mandible forward, usually the buccal segment relationship is a class 1, because this malocclusion usually is not severe as the skeletal one. As we said as well, we expect to have a crossbite. That's by definition. That will be, and not necessarily, sorry, by definition, that because the lower incisor is anterior to the cingulum plateau, so sometimes we expect to see an anterior crossbite, sometimes a posterior crossbite, and the crossbite can be generalized. So we understand why we can see anterior crossbite, because it's kind of like the lower incisor should be slightly ahead of the upper incisor, which kind of makes sense to see some anterior crossbite. But why do we see a lot of posterior crossbite? The answer, because of the anteroposterior discrepancy between the maxilla and mandible. How is that? Now, if you look at the black color, this is the maxilla, the purple or the pink color is the mandible. So the mandible and the maxilla, they are wider posteriorly than anteriorly. So if I move this mandible forward, as we're going to do here, the wider part of the mandible is going to occlude with the narrower part of the maxilla, and as a result we're going to have a crossbite. So it's quite often to see a patient with posterior crossbite in a class 3 patients. So now we covered the features of this malocclusion. What is the management? Now always we have them. We have 4 options: accept, growth modification, camouflage, and orthognathic surgery. But in a class 3 we're going to add the 5th one, which is upper arch treatment only, without doing anything for the lower arch, and we're going to see why. So the first one, accept. Well, it's always an option if the patient is happy with his profile, and the most important thing, there is no functional problem, then there is no need for treatment. So you just need to make sure that you don't have a functional problem, which basically the displacement. But if the patient has an anterior crossbite with displacement, as we can see here, he has to be treated to avoid recession of the lower teeth, because we're pushing it forward all the time, to avoid attrition of the upper incisors, and we have a little bit of weak evidence suggesting that this crossbite with displacement can cause TMD. As we are talking about the accept, before we go to the second option, growth modification, just remember that we do interceptive treatment for a patient with anterior crossbite with displacement to avoid, as we mentioned before, any damage to the TMJ. This can be done using either removable appliance or fixed appliance. We call it 2x4, where we move the teeth and correct the crossbite. So the second option of the treatment is growth modification. Growth modification is always an option. We will cover this in more details when we talk about functional appliances. But the types of these functional appliances for class 3 are called chin cup, which basically direct the force toward the condyle, trying to minimize the amount of the growth of the mandible. The other option is to use reverse quint block, so basically it kind of pushes the mandible posteriorly and the maxilla forward. Then we have Frankel 3, which relies on, as you know, the soft tissue and the expansion without moving the teeth. So basically the lower incisor will retrocline, the upper incisor will procline due to the pad that we have here. It eliminates the lip pressure, allowing the incisors to procline. face mask as well, in which protraction headgear to move the maxilla forward. Sometimes we use it with RME. There's an evidence that it will increase the effectiveness if we use it with RME. So you use a face mask, and from the evidence we know that what's going to happen is retroclination of the lower, proclination of the upper, a little bit of anterior displacement for the maxilla, mainly the posterior downward and backward rotation of the mandible. So as you can see here, the open bite is increased. Here's the RME, and here's the positive overjet. So the feature that we like to use a protraction headgear, patient between age 8 to 10. Maxilla should be hypoplastic because we are working on a maxilla. It's a mild discrepancy because we don't do a lot of skeletal correction. It should be reduced lower facial height because we're doing downward and backward rotation, so you need to compensate for that. If average inclination of the incisors will be better because again we're doing mostly dentoalveolar effect, and normal to mild prognathic mandible, so you don't have a severely prognathic mandible because the only one to fix that one is surgery. So the main topic of the lecture today is the camouflage. How can we camouflage a class 3 patient? So usually the aim of the treatment will be to develop the A point. We need this A point to move forward because you said that it's a hypoplastic maxilla, the main etiology for this malocclusion. And again, because it's the maxilla, we can either dentally moving the A point forward or skeletally moving the whole maxilla forward, doing either functional, as we said before, or surgery. And because we can't restrain the growth of the mandible, all what we need to do to reduce the severity is to do encourage the mandible to do downward and backward rotation. And that's the second reason why we like patient with anterior growth rotation for a class 3 rather than patient with posterior growth rotation, because if a patient has a posterior growth rotation, we can do even further downward and backward rotation of the mandible, and we can use combination of all of them. So what are the features in which you have in your patient that you have to look at to decide whether or not we can go for a camouflage treatment? The first one is a good overbite, and as we mentioned that to get a stable results you need to have a positive overbite at the end of the treatment. So if your patient walk in with a good overbite, that means that that's an easier case to treat. If the patient can achieve edge to edge, that is even better, because when the patient achieves edge to edge, that means that the overjet is 0. So for example, if a patient has a crossbite with displacement and the overjet is 4, and then you put him with this edge to edge, that means it's 0. So that means the minus 4 millimeter overjet is purely due to displacement, and the case is much easier than it looks. We try to see a patient who has a low SNA. As we said before, we want to move the A point forward. It's better if they have a reduced lower facial height, so we can do the posterior, as we said, the growth rotation we want easily. No dental compensation. You know that when we have a class 3 malocclusion, the upper incisor will be proclined and the lower incisor is retroclined, trying to compensate for the skeletal discrepancy. The less dentoalveolar compensation we have, the more camouflage we can do to the patient. And again, low SNB or normal SNB, because simply if we have an increased SNB, prognathic maxilla, nothing we can do but surgery. And if the patient has finished the B growth spurt, that would be even better, because if your patient is not finished the growth spurt, he will continue growing. So if you started the treatment, for example, a 14 years old kid, you did the extraction, you did the retraction, everything class 1, perfect. You are just about to debond and the patient is 15 and a half, and all of a sudden the growth has come again and the mandible is grown forward and the patient now has a reversed overjet. For that reason, if the patient has finished growth, that will be better for a class 3. Now, once we corrected the displacement associated with class 3, we prefer to see a molar relationship not more than half unit class 3. Now, some authors trying to put numbers into when to go for surgery, and one of them is Kerr at the Glasgow University. So he came up with the conclusion that if the A and B is less than -3, lower incisal inclination is less than 82, and the holdaway angle less than 35, then this patient indicated for orthognathic surgery. However, if you go back and you look at the Kerr's study, you notice that Kerr's study was a retrospective study depending on the Glaswegian consultants or maxillofacial surgeon. When did they decide to send the patient for surgery and when not? So they noticed that, okay, the orthodontist, when he see that the lower incisor inclination is 83 or more, he stop and he say, okay, I want to refer this one to the surgery. The surgeon see that, the surgeon start the operation. So these numbers are not quite accurate because it's dependent only on couple of patients, 90 or 20 I guess, and also it depends on the patient or the orthodontist and slash surgeon perspective on which the study is done. So it's more of an opinion rather than evidence that we can rely on. So how to correct a class 3? First, non-extraction treatment and using class 3 elastics to mesialize the lower segment. To distalize the lower segment and mesialize the upper segment. It's completely the opposite for what we did in a class 2. Extraction with differential space closure. Again, as we said, in a class 2 we go for upper extraction. If you have to do the lower, we have to go to the 5. While in a class 3 cases, we go to the upper arch extraction, and if we need it, we take the lower arch extraction and distalization of the lower teeth. So let's start one by one. If you have a patient with the class 3, now in order to fix this one, you need either to distalize this lower teeth posteriorly so that the 5 will move to the embrasure between the 6 and 5, and that would be a class 1. Or this mesobuccal cusp, if you want to think about it this way, has to move all the way forward until it is in the groove. That can be done either by doing simply an extraction here and allow this tooth to move forward, or to do extraction here and allow this tooth, to do extraction in the lower arch only, because when you do extraction in the lower arch, we have to finish in a class 3 full unit, and then you track the canine into class 1, and this will be a maximum anchorage case. So again, just to recap, we can fix this class 3 by either extraction in the lower or extraction in the upper and lower, but we prefer lower 4s and upper 5s, or by distalization of the lower segment. And we mentioned that the only people who are doing this at the moment or are the best at it is Asian, because they have a lot of class 3 cases with no prominent skin. Now the other option is to do, the first option is to do a non-extraction treatment. So as you can see here, the patient has a class 3, a little bit of hypoplastic maxilla, a little bit of orthognathic mandible, as you can see here. So basically he is class 3 malocclusion. So whenever you decide what is your treatment for the class 3, you need as well, we said, to consider the patient's profile. If the patient has really prominent chin, then extraction and retraction will make his profile look worse. And here, it's not a prominent chin, and also we will not end up retroclining the lower incisors a lot. So we decided to go for him with a non-extraction treatment. This is him before, full unit class 3, a molar relationship, and reverse over jet. Simply, patient started fixed appliance, goes with class 3 elastics, and here he's done. Everything is a class 1 with no need for to do extraction. Now some say that all what we did distalization, and the answer is no. If distalization can be done with elastics, we'll do distalization all the time. But what happened, basically a little bit of distalization and mainly a lot of proclination and mesial movement of the lower teeth. Now something to notice here, that this is the patient after treatment, and this is before treatment, and as you can see that his chin becomes smaller, as if I have done an orthognathic surgery for him. So I'll be saying, okay, my treatment is perfect, I did this treatment and patient didn't go for surgery. Well, the answer is not as simple as this. If the patient can achieve edge to edge, then he will move and posture the mandible forward, so he will look more severe class 3. While when you do the treatment and you eliminate the displacement, then you eliminate any movement forward, so then the patient will look without a mandibular prognathism. The second option is to do an extraction treatment with differential space closure. So if you can see here that the patient has a half unit class 3 molar relationship and canine relationship. Canine is distally angulated. We have a moderate crowding in the lower arch, mild crowding on the other segments. Midlines are coincident. So what we can do for this patient who already have a reduced lower facial height, that's another sign that this is not a good candidate for treatment. So what we can do is to do an extraction treatment. Now the treatment can be extraction in the lower arch only, as it's as we've said, it's completely the opposite to the class 2, in which we extract the lower 4s to allow to align the canine. Or the other option is to go for lower 4s and upper 5s. Now upper 5's extraction will allow the molars to move forward. That will help us to control the overbite, and sometimes if we need a space for alignment, it can provide space with maintaining the upper incisor position, because you will not end up over retracting the incisors because you extracted the premolar. As we can see here, all the premolars are there and the canine, while here one premolar is there and the final molar relationship is a class 3. However, whenever you have a class 3 and you have a little bit of crowding in the upper arch that need to be resolved, we can go for extraction of the lower 4s and upper 5s. That will help us to control the overbite. The third option is to do distalization, and actually the people who are good at this one are Asian. They do a lot of TADs in the buccal shelf, and then they retract the whole labial segment posteriorly. We have another method in which basically using, instead of TADs, you're using plates, and the reason to use blade because they are more stable, and then you attach these plates into a hook attached to the arch wire, which will result in distalization of the whole buccal segment. Now, as we are talking about the camouflage and the management, you just need to know that sometimes we use removable and a fixed appliance in a treatment of a class 3 patient. So for example, here when you see this patient, she has a crossbite, she has a slightly deep overbite. Any braces I'm going to place here is going to fracture. If I place a glass enamel, it could fracture or deepen the bite. So one of the best options to treat is to use simply a removable appliance, and that have a double cantilever in the front and 4 Adams, 2 on the right and 2 on the left, that will retain the appliance. But again, removable appliance alone is not good, because what's happened here, that it corrected the crossbite, but it did not correct the spacing, it did not correct the ectopic canine, and the reason is simple. Removable appliance can do only tipping movement, and also they can do a single tooth movement, not a multiple tooth movement. So basically here you need to move these teeth together. You can't then move this one and get the canine down at the same time. You need to give space. So here, as you can see, the fixed appliance stage and all of done. So just remember, retracting the lower incisors is likely to make the chin look worse, not better. Now, to overcome this problem, extraction of the mandibular an extraction here of the mandibular first molar and second premolar with a class 3 elastic is not the best option for a patient with a compromised profile. And you remember that when you treat patient with a class 3, that if he has a prominent chin, try not to extract, or if you have to extract the lower incisors. That will not affect the patient's profile. So if you can see here for this patient on the right, she has kind of posterior lower lip forward, and that's because of the lower incisors moving it forward. We don't have any prominent chin, you hardly see chin. So orthognathic surgery and advancement of the mandible. While in this patient here, as you can see, he has a prominent chin. So any extraction and retraction of the lower lip will worsen the appearance of this patient. And the fourth option is orthognathic surgery. So when we go for orthognathic surgery, if the patient came to the clinic and say, okay, listen, I don't like my profile, at that point, even though you can camouflage the surgery, you have to send him for surgery. This is the only option. It can correct his face. So if you can see this patient here, she has all the features that paranasal hollowing is there, and nasolabial angle slightly increased. All of these features of class 3 that the patient didn't like. If you go intraorally, you can see that the patient has a posterior crossbite, and as we mentioned before, that's because of the AB discrepancy between the upper and lower teeth. Then he went into fixed appliance stage, she went, and then the surgery. Surgery have done a huge improvement in her profile, and that's something to keep it in mind whenever you offer class 3 patient surgical option. The last option of treatment and the management of upper arch treatment alone. So what is that and why do we need it? So if you have a patient like this, who only 14 years old, with a class 3 skeletal and a strong history of a class 3, that she used to come with her dad, and her dad is a class 3 as well. And when I asked her, how many siblings do you have who are a class 3, she said maybe 5. So it's a lot. From these kind of history taking and examination, we can realize that she is at higher risk of growth again and worsening of the class 3 malocclusion. Okay, so what's the problem of starting treatment now, and she will worsen anyway? Well, if you start treatment in the upper and lower that involved extraction, for example, and let's keep thinking out of it. So if patient came to the clinic, she's like this one, 14 years old. We decided the treatment plan for her: extraction, lower folds, retraction of the lower incisors. All is done, all is perfect, all good. But then all of a sudden at the 16, the mandible grow suddenly, so that now we have a negative overjet that is big and it was not camouflaged before. And also that can get even more severe. So if you extract in the lower and then you say, okay, I'm going to do tidy up the teeth, and then the growth happen and the patient is not happy and he want to go for orthognathic surgery, at this point you realize the mistake of extraction of a permanent tooth. Because simply you need to decompensate, so you need to push the lower incisors forward. And what's going to happen when you're trying to push these lower incisors forward to correct this malocclusion, you will end up with no space that is left for you to correct this malocclusion. So again, you lost your space during the camouflage treatment. Now you don't have any space for another camouflage if the growth happen, and if the patient required surgery, then again you can't you will have to push the lower incisors forward to the point that you need to open space for these missing teeth that you already extracted. So as this patient here, who by the way, as I said, she has a strong family history, she has a bilateral crossbite, she's a class 3, all what we did for her just alignment, so she will happy and just accept the lower arch. So what about retention? Now, as we said before, we need to retain for life, but what are the factors that increase the retention or the stability? Overbite. So if you have a patient like this with deep overbite and you retract the lower incisors, then you finish the treatment and the lower incisors is trying to go back where we started, but it's just stopped by the upper incisors. However, if the patient has a reduced overbite or anterior open bite, as we can see, we retract the incisors. Now the lips is not happy, they are pushing the incisors to go where we started. It does because there is nothing to prevent it from going there. Thank you very much for listening.